Shall I start? Thank you very much. My presentation today is single incision reduced port laparoscopic cholecystectomy, current status and critical review. I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. Arthur Schaffner had beautifully written that all truth passes through three stages. First, it is ridiculed, then it is violently opposed, and finally, it is accepted as being self-evident. I think in laparoscopic era, all of us have seen all these three phases of truth. When we started our laparoscopic career in 92, 93, laparoscopic cholecystectomy per se, and then we started our single incision journey way back in 2000, and then when we started our robotic journey in 2012, similars were the status. I do not want to go into the details that how many terms, how many abbreviations have been used for this single incision laparoscopic cholecystectomy, but this is not a new concept. It was written, a beautiful article had come by Navarra in 1997, and he had performed 32 cases of cholecystectomy, but he realized that it is technically challenging, decreased range of motion, sword fighting is there, and long operative time is there. And after that, many surgeons tried this single incision, and many procedures have been done in all general surgery, urology, gynecology, and so on and so forth. So the thinking is that whether it is feasible, yes, it is very much feasible. One has to make sure that any and every gun is safe. The man behind the gun has to be safe. What I mean to say, safety is surgeon oriented. It is not because of the instrumentation. Results, we will go into details, and there are definitely limitations of these procedures of single incision. There is a beautiful comparative study of single incision versus conventional laparoscopic 4-port cholecystectomy, and in this, the advantages which have been enumerated beautifully are that less pain in sills and reduced analgesic usage, higher cosmetic satisfaction, decreased hospital stay, faster return to normal activity, which were the goals of the laparoscopic surgery. The disadvantages are longer mean operative time. Definitely in the beginning, all of us, when we started our laparoscopic single incision surgeries, we used to take maybe 1.5 hours, and then gradually now we are taking 20 minutes for single incision laparoscopic cholecystectomy. It all depends on the repetitions which we carry on doing it. Technically difficulties in obese patients, yes, in the initial phase, BMI above 35, there was a relative contraindication. But now we are doing single incision sleeve gastrectomies in BMI of 35, 40, 45. So thinking is definitely the time with the experience, with the expertise, the relative indications and contraindications change. Higher operative cost. Yes, initially when the single incision surgeries were started, many surgeons had used the Covidian 3 ports and tri-port and quad port and so many ports, but ultimately realization, now we have also gone through all this blood under the bridge, but we have realized nothing like your own children, nothing like your own instruments, and we are using the long instruments, the bariatric instruments, the same scope which we have been using, that is 30-degree 10 mm scope, and ultimately realization is that in comparison, when we do single incision versus 4-port cholecystectomy, the bile duct injury is not increased according to lot of literature. The thinking is that yes, surgeon has to be cautious, and the advantages of single incision, all of us know that no visible scar, less post-operative pain, less blood loss, faster recovery time, less complications, and so on and so forth. Again, publications have come about the quality of life also after single incision laparoscopic cholecystectomy. Safety and efficiency of single incision cholecystectomy, especially in obese patients also. In this, again, it was noted that the post-op complications were not significantly different. Length of hospital stay was not different, but definitely because the concern is when we are making an incision intra-umbilical, it may become more than 10 millimeter, maybe up to 15 millimeter. Our thoughts are, and initially, all the surgeons who are not trying their hands on single incision, they always opposed that the chances of incisional hernia will increase. But thinking is that if you know that the chances of incisional hernia will increase, take adequate precautions. Especially in obese patients, we always close it with proline suture, whereas in other thin patients, we close it with PDS, but making sure that failure is not an option. We should not leave on to hernia. Later on, we had a publication in Journal of Minimal Access Surgery on single incision multi-port laparoscopic appendicectomy, and then we realized that we should carry on with single incision surgeries. And this year, I know that President Pryor is also sitting here. This paper has been accepted for single incision laparoscopic cholecystectomy in situs inversus totalis. What I mean to say, in laparoscopic surgery, all of us know that situs inversus totalis is a rare disease, but definitely if one can stand in between the legs and use these kind of grasper in the hypochondrium, and then we are able to do the single incision laparoscopic cholecystectomy in situs inversus also. That means we have done maybe more than 1,000 cases of laparoscopic cholecystectomy, then only we will venture into it. And in this situation, what we did was that we placed two ports. One in the, and normally also we place 10 millimeter port intra-umbilically, and that is a OptiView. We always believe that eyes don't lie. One has to go layer by layer into the peritoneal cavity after pneumoperitoneum. And once we go into the depth of the umbilicus with 12 mm port, then we make 5 millimeter port into the umbilicus, that's all. Initially we were making 3 ports intra-umbilically, but now we are making 2 ports intra-umbilically. And this is the alligator grasper which we are using, and it is 2.3 mm. We don't need to suture that, we do not need to close it, and ultimately because of the excellent traction, people have used the sutures through the gallbladder and the bile spillage can occur. But if you are using this kind of alligator grasper and if you are using the energy sources judiciously, then obviously the gallbladder spillage is not there and you are able to complete. And again, the thought process is that we should be cautious of critical view of safety. If we do not practice the critical view of safety in 4-port cholecystectomy, then we will never be able to perform the single incision cholecystectomy with critical view of safety. Thinking is that we should always dissect the posterior aspect, and then we should make sure that at the time of clipping, there are only 2 structures. One should be called as cystic duct, another should be called as cystic artery. Thinking is that if we are able to do the dissection in the same manner by standing in between the legs, the monitor is on the top end of the patient, and then we are able to carry on thinking that safety first, safety, there is safety and more safety, and then we are able to do the cholecystectomy safely. Nothing like it. Patients are more comfortable, and we have also submitted our data on comparison of 4-port cholecystectomies done by our unit in Gangaram Hospital and in Bhatia Global Hospital, and we are doing this single incision. 90% of our cholecystectomies are single incision. So we have submitted the data, and now you can see that now we have cleared this window. The big surgeons make big windows, and then we apply these clips, and we have got the 5 mm clips. Also Ligamax is also available. But if the scope of 5 millimeter is available, then we can change the 5 millimeter scope into the 5 millimeter port, and through the 12 mm port we can use the routine Liga clip applier, so that ultimately we are not compromising on the cystic duct or on the cystic artery. We should always milk it, so that we do not miss the stone and then apply the clips, and then we always remove the gallbladder in the endo bag, so that failure is not an option, infection is not an option. We should never ever think that we should cause any infection in the umbilicus, because most of us know the complication of infection, one, and second is the incisional hernia at the port site. They are important, so we should take adequate precaution for delivery of the gallbladder also. This is the ultimately same day that we had done the single incision cholecystectomy, and then another scar is not there. The inclusion criteria for single incision reduced port cholecystectomy is symptomatic cholelithiasis, gallbladder polyp, and adenomyosis. But again, exclusion criteria for us is, for example, acute cholecystitis is there. One should always carry on thinking. It is not that one trouser will fit every patient. It is, for example, if the patient is having acute cholecystitis, mass is palpable, tender, it is tender, we definitely would go with diagnostic laparoscopy, and then we have a low threshold of making 1, 2, 3, 4, whatsoever number of ports. It is a reduced port surgery rather than only we are hell-bent that we have to be giving a single incision laparoscopic cholecystectomy. Similarly, biliary pancreatitis, Mirizi syndrome, cirrhosis, high risk, and so on and so forth. Thinking is loud and clear, safety first. If we are able to deliver the patient safely, for example, in this situation, you can see the cystic duct, we have done a posterior window dissection, and then we are milking, and then we find that definitely the cystic duct is wide. So if the cystic duct is wide, we can always put in a suture, and in this situation, what we do is that single incision, single surgeon, single-handed suturing, and now you can see that we are putting a knot with the vicryl number 1, and the other end of the suture is outside the 5 millimeter port, and then we are tightening it by making the loop to the surgeon's throw, then surgical knot, and then knot, so that ultimately we are not compromising. Thinking is that many times many people will think that if the cystic duct is wide, then you apply these clips in a step ladder fashion. No, our thinking is nothing like your own babies, rather than test tube babies. You should always believe on suturing, and if we suture the wide cystic duct and making sure that the stones have not slipped down, then only we will be getting the best possible results. We should remain very close to the gallbladder cystic duct junction rather than CBD cystic duct junction. And another aspect is, for example, now in this situation you see that the stone is beautifully stuck, and we are doing the milking. Then what we do is that we apply the suture or the clip onto the gallbladder side, and then open the cystic duct as we would have done in 4-port conventional cholecystectomy. That means we take the stone out, milk the stone out. Now you see the stone has been taken out. It is a wide cystic duct. We are making sure that there are no other stones in the cystic duct. We do not want to have a remnant stone in the post-op period. And then we can apply the suture with the help of needle also. That is single surgeon, single-handed, single instrument, intracorporeal suturing, and that can also be done with the help of single incision. But I would not sell it to our younger colleagues. If the younger colleagues start with these kind of patients, definitely the chances of biliary tract injuries or making them biliary cripple are higher. So once we have done good number of cholecystectomies, once we have done more than 1,000 single incision laparoscopic cholecystectomies, then only we venture into doing the suturing. Otherwise, if one is not deft with the suturing, one can always make 1 port, 2 port, 3 ports and do the complete suturing, and then maybe leave the drain also, so that there is no compromise on this aspect. Definitely, I would never ever end up with saying that everything is rosy. One can have the complications, and complications can be perioperative, perforation, biliary spillage, or hemorrhage. Now, in this situation, for example, I was doing a mini laparoscopic cholecystectomy, and you could see that as soon as I held with this mini lap grasper, we had a bleeder from the cystic artery, and you can see the bleeder. But again, with the experience, we could push in 5 mm port, and then we just placed in a 5 mm liga clip, and then the suturing stopped, and then we again continued, and it is called as a mini laparoscopic cholecystectomy rather than single incision cholecystectomy. Thinking is patient safety first rather than anything else. And definitely post-operatively, one should be cautious about wound infection, hematoma, biliary leakage, biliary stricture. If you are very close to the CBD, the stricture can occur. Residual cholelithiasis, again and again, importance of milking the cystic duct, and incisional hernia that I have narrated. So in conclusion, sir, with proper patient selection, conversion to 2 ports, 3 ports, 4 ports, open cholecystectomy, the complication rates are definitely low. Instrumentation improvements have occurred. So many kinds of ports have been there, but ultimately we have realized nothing like long bariatric length instruments. Long suction we have already got made, long clip applier, this scope may be long 45 degree or 30 degree, and the camera person should be excellent. Then only we are able to perform the single incision cholecystectomy in a safe way. And we have been practicing robotic surgery. All of us know the latest generation of robotic surgery has single site or one site robotic cholecystectomy is also being done, and one site other procedures are also being done. So thinking is, let us have the mind open rather than closed. You cannot stop the waves, but you can learn to surf. Thank you very much. Thanks a lot. Be not the first when the new is tried, nor yet the last to lay the old aside. Thanks a lot. Thank you very much.
Excellent presentation, Dr. Bhatia. I have 3 questions for you.
Sure.
Seals in a case of acute or chronic gallbladder. Second question, how do you deal with a frozen callots? And third question, what were the situation where you have to make another additional port?
Good. I think I have answered that we have a low threshold of putting in the 1, 2, 3 ports. What I mean to say, to add to this, I would always say that we never promise the patient in the pre-operative period that I am going to finish the single incision cholecystectomy. We always say that gallbladder has to be taken out and it will be done by the laparoscopic method. But when we go in, we put in it first 12 mm port intraumbilically, we go with the intent that we will be able to complete it with single incision. But on, for example, diagnostic laparoscopy, if we find that pyocele is there, mucocele is there, in the initial phase, we definitely had a low threshold of putting in another 5 mm port in the epigastric region. The same alligator grasper on the right side or 5 mm port, and then could complete the cholecystectomy. Similarly, in acute cases also now, with increasing experience, we have been able to do it, but I would not advocate for younger colleagues that right from the beginning they should choose those kind of patients of acute onset or acute cholecystitis. One, if the frozen triangle is there, cystic duct, this triangle is there, then there is no ego which will tell you that please carry on with the cholecystectomy. No, I think ego has to remain outside the operation theatre. So one should carry on thinking that yes, if we are not able to dissect the cystic duct and the artery, we are not able to satisfy the critical view of safety, it is not a doublet view, then we should always make sure by seeing your own expertise, make one port in the epigastric port, 5 mm or 10 mm, right hypochondrium, another one, so that patient is not having unsafe cholecystectomy. We always, frankly speaking, we always tell our surgeons, younger surgeons, do you want that you should become a safe surgeon or a fast surgeon? And answer is yes, I should be a safe surgeon. And I ask the patients also, do you want a safe cholecystectomy or a fast cholecystectomy? They always say that we want a safe cholecystectomy. So thinking is there is safety in more safety. And in complications like this, for example, if the bleeding is there, one can always put in 1, 2, 3 ports. Yes, sir.
Any questions from audience? I am expecting questions to Dr. Bhatia.
Sure.
Good morning, sir.
Good morning.
Very excellent presentation.
Thank you.
I want to ask you regarding the incision, whether how you give a incisions, whether it is supraumbilical, umbilical,
Good.
smile incision or other incision.
Sure. I definitely could not justify that. What we do is that this is the umbilicus, and we always make intra-umbilical incision with the help of 11 number blade. We go to the well of the umbilicus with the tip of the 11 number blade facing upwards, and then give an incision on the upper pillar of the umbilicus, so that ultimately I always say that God has made the umbilicus only for the surgeons. So we should utilize the depth of the umbilicus. So once we are making a vertical incision intra-umbilically, and then with the help of artery forceps, we dissect the camper and scarpa fascia and the subcutaneous tissue, then we are able to see the rectus sheath or linea alba, and then we always put in a Veris needle, and that's it. The closure of vertical incision, I showed you the photograph of single incision, situs inversus also. The closure of the vertical incision is always better. It will not give any scar. Many times, most of the patients, after maybe 1 week or 7 weeks or 5-7 weeks, they are surprised that where is the incision, from where did you remove the gallbladder? So vertical incision, intra-umbilical, in the depth of the umbilicus.
Yes, sir. And another question is that how many complications like you mentioned the hernia? This, have you encountered your patients?
Touch wood, we have not had the hernia on our patient, but we had 2 patients who had got the single incision surgeries elsewhere, and we could see that there was a hernia, umbilical hernia at that side, and we did the suturing and the IPOM later on after 3 or 4 years. So thinking is that if we know that hernia will be common, then we do not have any hesitation to increase the size of the intra-umbilical incision. It can be extended up, it can be extended down, and then with the help of a back of the forceps, we always lift the abdominal wall up and then take the suture through the sheath with PDS or with proline, so that failure is not an option, so that herniation should not occur.
Yes, sir. Because you have did the, looking to anything like there, you repair the thing with anatomically, exactly to see, looking to all the things. That's why probably you have not encountered the hernia.
Exactly. If I know that if I do not take my window glass or this side glass or rear view, an accident can happen, why should I not take it out? What I mean to say that when we know that hernia can occur, we should always make sure that we should repair it there and then, rather than waiting for the hernia to develop.
Yes, sir. Exactly. You said ego should be outside the OT.
Exactly.
Then can prove like that only.
Thank you for appreciating that.
Last question, sir. The noting you have shown there. How you this thing another taxon should be required, whether the suture is another suture is keeping outside the port or what in the abdomen.
What I mean to say is that when we have got a wide cystic duct and we have to suture that, we take vicryl number 1. And non-needle ended suture is taken in through the 5 mm port with the help of Maryland dissector. And then we encircle the cystic duct and take a suture. That length of the suture approximately is 4 to 5 inches. And then with the help of the scope is in 5 mm needle driver or the Maryland dissector is there, we are pulling the other side of the suture outside with my left hand, and then by supination and pronation of the instrument and the roticulation. I think most of the surgeons are not utilizing the roticulating movements of the Maryland dissector. So if you are using the roticulating movements of the Maryland dissector, you are able to make a surgeon's throw, you are able to make a square knot, and then you can tighten it as much as you want it, because you are putting the pressure from outside, and you, with the help of Maryland dissector, you are pushing the tail end on the other side. Then we are able, and what we do is, and beautifully asked, what we do is that in such situations we place 3 sutures. 2 on the proximal side, 1 on the side of the CBD, and 1 on the gallbladder side, so that 1, the spillage is not there. 2nd, we are away from CBD, we are not causing biliary stricture, and we are not leaving any stone behind.
Thank you, sir.
Thank you. Thanks a lot.
Yeah, one more question.
Sure.
Hi, sir.
Yeah, Bindal. Yes.
So just an observation. Rather than taking the intracorporeal knots, which I'm sure would be easy for a person who has a large experience, like you said, for a surgeon who is learning single incision cholecystectomy, wouldn't an extracorporeal knot through a single port be easier to place and to deliver rather than placing an intracorporeal knot?
Absolutely right. We always believe that it has to be a step-by-step growth. We should not go to the college and then to the nursery. Our thinking is that when you are born, then think, yes, definitely when you are starting. And if you have any challenge in your suturing, please go ahead and make 1, 2, 3 ports so that there is no compromise on the safety. That is the point about the critical review which I want to impress here. So if you have a challenge in suturing, yes, before that we tried the endo loop, but my objection to endo loop was that it was a chromic catgut. And I would not love to place the chromic catgut on the cystic duct. If we can make our own endo loop, and we make it with the help of vicryl suture onto this, and then we had guided this onto the cystic duct stump, and then we are able to do it. So thinking is that one has to progress step by step. And now this is the latest one which I showed you the video, and I think this was done last week only, that we could take the needle in and put the 2 lips of the cystic duct sutured with the help of needle, and then we could reticulate, making a surgeon's throw and square knot, and safety was there.
Thank you, sir.
We'll take one last question.
Sure,
It's not a question, it's a comment.
sure.
I know Professor Parveen Bhatia. He has been very helpful in the initial days I was learning lab coding. I'm sure he doesn't remember me.
Thank you, sir.
I have, it was a small nursing home in a remote area of Delhi where we had hardly, in that hospital, even open gallbladder or laparotomy hadn't been done. And he was watching me do a lap coding when you showed the video of the cystic artery bleed. You asked Raju, hold it, pakad jaldi se. The way you have progressed, it is amazing.
Thank you, sir.
I'm very pleased to see this. I wish, Parveen, we should, the days at that time when we were learning, we said anybody who's done 50 lap open colis then should only attempt a lap coli to open it. Now, what is your view? How many lap colis one should have done, then attempt single, sills?
Wonderful.
Even in UK, it's not being done.
I know.
I claim that anybody in M25 area, any consultant has learned lap coli from me.
Sure.
But what should be the maximum number? Because it's a very good procedure, but you need clinical acumen. You need the sentence you used was keep your ego behind. No arrogance inside. Humility makes you. I'm so proud of you that when I came last year, I said I remember the date. Manjula nursing home. I remember the.
Thank you, sir. Thank you, sir. But short answer to this is, we should always introspect. If I introspect within my own self that I have done maybe thousands and thousands of conventional cholecystectomy, and then when I started our career of single incision cholecystectomy, definitely we had a threshold of conversion to ABC 4 ports, but with some kind of doggedness, And literature also says that if you have done good number of laparoscopy, and in the initial phase, if you are with a surgeon who is practicing single incision for at least 25 cases, you are able to see how the camera person is performing. My thinking is that I as a surgeon, I may be good, you may be good. But if the camera person does not want to cooperate with you, or he does not know that this is the way that one has to show with the 30-degree scope, we will not, because of the cluttering of the instruments inside. So thinking is 25 cases, one should see the surgeon who is performing, and then one should start with the surgeon standing by the side of you, and then once you are able to do it, again and again thinking that you are a cerebral laborer rather than a manual laborer. If you have to convert to 1, 2, 3 folds, go ahead, do it. But doggedness is required.
Thank you, Dr. Bhatia.
The mind doesn't know what the eyes do not know what the mind doesn't know. You have to have that.
I always say that eyes cannot see when the mind is blind. Eyes cannot see when the mind is blind.
Sir, are you always using multi-ports, single incision multi-ports, or using the single ports?
Wonderful question. We, in the initial phase when we started, we were using 12 mm port intraumbilically and 2 5 mm linear ports intraumbilically, one at 11 o'clock, another at 7 o'clock. But we were not using the alligator grasper. I attended one of the meetings in SAGES long time back, and I saw this striker alligator grasper, and it was 2.3 millimeter. Immediately I purchased that, and after that I have been using this, and then now we have reduced the 1 5 mm port into the umbilicus and 1 12 mm port into the umbilicus, and that's it. So that ultimate, and this 5 millimeter port is at a distance. The 12 millimeter port is direct, but this 5 millimeter port is at around 11 o'clock. So we need not even close it, because it is we go horizontally and then go vertically into the abdomen with the pneumoperitoneum.
Your striker alligator is wonderful. I also bought a few.
Sure.
But now it is not available.
Yes, wonderful. I think it is an excellent observation. Now the striker is not making it, but we have copy pasted. We are Indians. So we have already copy pasted it, and we get it made. And if you want, I can send it to you. We have got made hundreds of alligator graspers. We had shown this model to them, and the handle has been changed, and it is now a reusable alligator grasper 2.3 millimeter.
But not as good as striker one.
No, we have got it made on our own with our own technician. What I mean is, I searched for it, and ultimately I have been able to do it. Just because I love the serrations of the alligator grasper. Beautiful serrations. It will hold the gallbladder. It will not puncture the thin wall gallbladder, and then we are able to do the justice.
Thank you, Dr. Bhatia.
Thanks a lot.
You
Thank
can
you.
ask lot many questions to Dr. Bhatia at the coffee break.
Sure.
So our next speaker.
Thank you. Thanks a lot.
Our next speaker, Dr. Laparoscopic.